I'm here in Tasmania as an invited guest for the National Continence Australian Foundation, and I'm delighted to be an invited speaker and participate in a meeting with a fantastic looking program of things I want to actually attend as a delegate, as much as I'm honoured to be speaking at. So I've got the good fortune to present on three areas which are sort of very close to my clinical and research interest. One on opioid-induced bowel dysfunction. This is a big deal as the prevalence of opioid usage increases in the Western world. And so just really a pragmatic approach about how to recognise it and how to approach treatment for it. Another talk about the real area of passion of my research, which is something called the brain-gut axis. This notion that there's a mini brain in here and a big brain in here, obviously, and how the two of them communicate on a day-to-day basis to allow us to know when we're hungry, when to eat, when to not eat, when to open our bowels, when to not open our bowels, that kind of dialogue that occurs between the two sides, and how that can get disturbed, and how we can try and think about managing that through manipulating the microbiome, the gut bacteria. And the third presentation is on pelvic and perineal pain, the problems that occur when patients come along with abdominal or pelvic complaints, and we're not quite sure whether it's IBS or diverticular disease or actually a primary pelvic problem. So it's really trying to get a clinical handle on how to approach that and recognise these common syndromes from the less common ones. I think the biggest challenge of continence care is the fact that it's a Cinderella area. The patients suffer immensely, but the symptoms are taboo, whether it's for the patient or their carer, and so we don't like talking about it. And yet the burden it presents to the individual and the families is immense. And so you're in this situation where you have patients who don't necessarily out themselves and self-manage, or if they do present, they tend to meet specialists or non-specialist care, shall I say, where they don't necessarily get a lot of insight provided back to them because services are regarded as rather thin, and because the amount of knowledge in the area isn't necessarily as well founded as it should be. And that's deeply ironic given how much there is one can do. At a basic level, there's a lot we can do to help incontinence. And so we're in this so terrible situation where there's a huge stigma, a general lack of knowledge, balanced by the fact that there's a lot we can actually do. So for me, the biggest challenge about this is the number one issue is to go and find cases in the community, identify the patients who are out there and suffering, and then help our colleagues who see these patients in primary care and the like to feel confident to ask the questions and then know what to do as first and second line therapy. I think educating our colleagues who see these patients is absolutely critical. It's not just the things that we tend to mentally associate like Neuro-Gastroenterology or geriatrics. It's also something we see in gastroenterology patients, in colorectal surgery patients, in general post-obstetric patients. There's a huge range of things where patients experience incontinence, neurological diseases. And I think we tend to ignore these in our training, and we assume that somebody else will pick up this problem. But actually for the patients, when they come to see us, they're telling us everything, or they want to tell us everything. They don't necessarily compartmentalise continence care as separate from their limb problems or their neurology or whatever else. And so I think the onus is on specialists to be better educated, to feel confident to manage the condition. So what's really close to my heart is bowel incontinence, which is, if we think about bladder incontinence as a taboo, fecal incontinence is even more so, because at one level there's a kind of the puerile kind of embarrassing element of passing wind without control. That's sort of giggly for a while, but actually when you're the victim, it's deeply mortifying, and so one shouldn't just laugh it off. We should make ourselves clear that happens and there's something we can do about it. And then as regards fecal incontinence itself, when one can't control soiling or holding on, again, the critical thing for the patients is that most patients try and manipulate their life. They avoid certain clothing, they avoid meal times, they avoid social situations, because they've learned that they can't do the school run until they've dealt with their bowel. So they either avoid meals, or they wake up at 5 a.m. to get their bowel cleared. And almost the biggest challenge is to make the patient recognize that they've taken on these changes in lifestyle to accommodate their symptoms, and that isn't normal. It doesn't have to be the way they need to behave. And so say to people, look, you don't have to get up at 5 a.m. we can treat you with this, and you can get up at 7:30 like everyone else and do the school run and get to work in time. And it's often just a question of trying to reflect back to the patient the changes they've made to manage their symptoms. So I think a lot of patients, their own incontinence is invisible to them because they've learned tricks about how to manage it to minimize the embarrassment.